السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lecture on venous return in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for this learning activity, and here we have the recommended learning resources for this lecture. Veins are important components of the cardiovascular system. They are thin-walled blood vessels with relatively large lumen. They have high degree of distensibility and high compliance, and hence they are considered as the capacity vessels of the cardiovascular system. They can accommodate large changes in blood volume with only little change in pressure until a particular limit is reached. Beyond that limit, any change in blood volume would result in a change in pressure. If we compare arteries and veins of corresponding size, we would find that the arteries have thicker walls than the veins, and the lumen of the veins is relatively large. The pressure is much higher in the arteries than in the veins. The arteries have lower compliance as compared with veins of corresponding size. Hence, arteries are considered as pressure reservoirs, while veins are considered as volume reservoirs. Structurally, veins have all the three layers in their walls: the tunica intima, the tunica media, and the tunica adventitia. But the layers are thinner than in arteries of corresponding size if we consider the external diameter of the arteries and the veins. Another additional very important difference between arteries and veins is that veins have paired semilunar bicuspid valves. These valves in the veins are important because they restrict backflow of the blood in the lower extremities. In varicose veins, blood pools in the veins of the lower extremities because the valves fail, hence causing the walls of the veins to expand, as seen in this picture of varicose veins. Since the veins are the capacitance vessels in the circulation, they function as variable reservoir of blood, with approximately 2/3 of the blood volume contained in them. So the systemic veins and venules can accommodate up to 60% of the blood volume, with additional blood in the pulmonary veins. So this is one important function of the veins. The other important function of the veins is that they collect and return blood to the heart. Hence, they are important in the venous return to the heart. We shall describe these two functions of the veins in more details in the subsequent slides. Now, let's describe how veins serve as blood reservoirs. It is very important first to note that when we say that veins serve as blood reservoirs, this doesn't mean that the blood which is contained within the veins is static. In fact, normally all the blood is circulating all the time. However, when the body is at rest, many of the capillaries in the various capillary beds in the body are closed, and the capacity of the venous reservoir is hence increased as extra blood bypasses the closed capillaries and enters the veins. When this extra volume of blood enters the veins, it stretches the walls of the veins and hence increasing the total cross-sectional area of the veins, and as a result of that, in the veins blood would move more slowly. Therefore, blood would spend more time in the veins. As a result of this slower transit time through the veins are essentially storing the extra volume of blood, because this extra volume of blood is not moving forward as quickly to the heart to be pumped out again to the tissues. When the stored blood is needed, such as during exercise, extrinsic neurohormonal factors reduce the capacity of the venous reservoir by causing venoconstriction and hence drive the extra blood from the veins to the heart so that it can be pumped to the tissues. The second important function of the veins is that they collect blood and return it to the heart. So the veins are important in venous return. Venous return is defined as the flow of the blood back to the heart. So here we have, this is the right-sided venous return from the systemic tissues, and here we have the left-sided venous return from the lungs. Under steady state conditions, venous return must be equal to the cardiac output when averaged over time. This is because the cardiovascular system is essentially a closed loop, as we described in the first lecture. Having said so, right-sided cardiac output, which is ejected into the pulmonary trunk and passes through the pulmonary circulation, should be equivalent to the left-sided venous return when averaged over time. Similarly, left-sided cardiac output, which is ejected from the left ventricle into the aorta and passes through the systemic tissues, should be equivalent to the right-sided venous return when averaged over time. Thus, right-sided cardiac output should be equivalent to the left-sided cardiac output when they are averaged over time, and similarly, right-sided venous return should be equivalent to the left-sided venous return when they are averaged over time. This is essentially done by the Starling mechanism of the heart. Venous return is determined by the difference in pressure between the venous pressure nearest to the tissue, which is physiologically known as the mean systemic filling pressure or the mean circulatory pressure, MCP, and the venous pressure nearest to the heart, which is physiologically known as the central venous pressure. We will then describe these two pressures in more details. The central venous pressure, CVP, this is the venous pressure in the right atrium and in the big veins of the thorax. Hence, it is equivalent to the right atrial pressure, and is also equivalent to the jugular venous pressure. Central venous pressure is measured with the catheter inserted into the central venous system, usually the superior vena cava. The normal range of the central venous pressure is from 0, which is the atmospheric pressure, up to 4 millimeters of mercury. Central venous pressure, or right atrial pressure, or jugular venous pressure, they are all equal, is important since it is the force which is responsible for cardiac filling. So it is therefore the force which is responsible for the cardiac output. We mentioned in the 2 lectures on the cardiac cycle that most of the ventricular filling during diastole is passive and depends on the pressure differential between the pressure in the atria and the pressure in the ventricles. We use central venous pressure clinically to assess hypovolemia and also during intravenous transfusion in order to avoid volume overloading. CVP is raised in right-sided failure because in right-sided failure the right ventricle ejects smaller stroke volume during systole, hence blood accumulates in the right ventricle, raising right ventricular pressure, and the raised right ventricular pressure is transmitted to the right atrium because blood would also accumulate in the right atrium, and this rises the right atrial pressure, which is the central venous pressure. Now let's describe the other pressure which affects and determines the venous return in more details. This is the mean systemic filling pressure, which is also known as physiologically the mean circulatory pressure, or MCP. This is the venous pressure nearest to the tissues. Its normal value is about 7 millimeters of mercury. It's difficult to measure this pressure, however, we determine it indirectly. The value for the right atrial pressure at which venous return is 0 is called the mean systemic filling pressure. Since venous return is driven by the pressure gradient between the mean systemic filling pressure and the right atrial pressure, as the right atrial pressure increases, this pressure gradient decreases, and hence the venous return decreases. Thus, when the right atrial pressure becomes equal to the mean systemic pressure, no pressure gradient exists between the venous pressure nearest to the tissue and the venous pressure nearest to the heart, and venous return stops and becomes 0. So the mean systemic pressure is determined as the value of the right atrial pressure at which venous return is 0. It is the point at which the venous return curve, which is also known as the vascular function curve, intersects the x-axis. In other words, it is the value where the venous return is 0 and the right atrial pressure is at its highest value, and no pressure gradient is thus present between the venous pressure nearest to the tissues and the venous pressure nearest to the heart. We will describe the venous pressure curve, the vascular function curve, in more details in the subsequent slides. The mean systemic filling pressure is affected by two important factors. The blood volume directly affects the mean systemic pressure. So the mean systemic pressure is directly proportional to the blood volume. As blood volume increases, the mean systemic filling pressure also increases. The other factor which affects the mean systemic filling pressure is the venous capacity. The mean systemic filling pressure is inversely proportional to the venous capacity. Hence, as the venous capacity decreases when the veins undergo venoconstriction, the mean systemic filling pressure increases. Now, let's describe the other pressure which affects and determines the venous return in more details. This is the mean systemic filling pressure, which is also known as physiologically the mean circulatory pressure, or MCP. This is the venous pressure nearest to the tissues. Its normal value is about 7 millimeters of mercury. It's difficult to measure this pressure, however, we determine it indirectly. The value for the right atrial pressure at which venous return is 0 is called the mean systemic filling pressure. Since venous return is driven by the pressure gradient between the mean systemic filling pressure and the right atrial pressure, as the right atrial pressure increases, this pressure gradient decreases, and hence the venous return decreases. Thus, when the right atrial pressure becomes equal to the mean systemic pressure, no pressure gradient exists between the venous pressure nearest to the tissue and the venous pressure nearest to the heart, and venous return stops and becomes 0. So the mean systemic pressure is determined as the value of the right atrial pressure at which venous return is 0. It is the point at which the venous return curve, which is also known as the vascular function curve, intersects the x-axis. In other words, it is the value where the venous return is 0 and the right atrial pressure is at its highest value, and no pressure gradient is thus present between the venous pressure nearest to the tissues and the venous pressure nearest to the heart. We will describe the venous pressure curve, the vascular function curve, in more details in the subsequent slide. The mean systemic filling pressure is affected by two important factors. The blood volume directly affects the mean systemic pressure. So the mean systemic pressure is directly proportional to the blood volume. As blood volume increases, the mean systemic filling pressure also increases. The other factor which affects the mean systemic filling pressure is the venous capacity. The mean systemic filling pressure is inversely proportional to the venous capacity. Hence, as the venous capacity decreases when the veins undergo venoconstriction, the mean systemic filling pressure increases. Now, let's describe the factors which affect the mean circulatory pressure, the mean systemic filling pressure, in more details by discussing and explaining these diagrams. On the x-axis, we have the blood volume in liters, and on the y-axis, we have the mean circulatory pressure in millimeters of mercury. The total blood volume in a normal adult is approximately 5.5 liters. This total blood volume can be physiologically divided into two volumes. The first volume is known as the unstressed volume, which is defined physiologically as the volume of blood in the vasculature that produces no pressure. So here we have, this is the unstressed blood volume. It is at this unstressed blood volume the mean circulatory pressure is approximately 0. The other division of the blood volume is the stressed blood volume, and this is the volume which produces pressure as a result of stretching of the elastic fibers in the blood vessel walls. So this is the stressed blood volume. This stressed blood volume causes an increase in the pressure in the vasculature as a result of stretching of the elastic fibers. At total normal blood volume, thus, the mean circulatory pressure is 7 millimeters of mercury. During hemorrhage, the unstressed blood volume would remain the same, but the stressed blood volume decreases. The stressed blood volume decreases, and the decrease in the stressed blood volume results in a decrease in the mean circulatory pressure. On the other hand, during infusion, the stressed volume increases. This is the normal. This is the total blood volume. And with blood transfusion or with the infusion of fluids into the vasculature, the stressed volume increases, and hence the mean circulatory pressure increases. Now let's describe the other factor which influences the mean circulatory pressure, which is the venous capacity. And we mentioned earlier in the lecture that the mean circulatory pressure is inversely proportional to the venous capacity. So as the venous capacity increases, mean circulatory pressure decreases, and as the venous capacity decreases, mean circulatory pressure increases. This is shown in this diagram. On the x-axis, again, we have the blood volume, and on the y-axis we have the mean circulatory pressure. In a normal subject, the total blood volume is approximately 5.5 liters, and the unstressed volume is 4.5 liters. When the veins undergo venoconstriction, the venous capacity decreases, hence the unstressed volume also decreases. Now with venoconstriction, the unstressed volume is 4 liters. The remaining 1.5 liters of the total blood volume would be stressed volume. So with venoconstriction, the unstressed volume decreases and the stressed volume increases. And we mentioned that the stressed volume is the volume which stretches the walls of the vasculature and hence resulting in an increase in pressure. So hence, when the stressed volume increases with venoconstriction, the mean circulatory pressure increases and now reaches a higher value than when the veins are not under venoconstriction. The opposite is true when we have venodilatation resulting in an increase in the venous capacity. When the venous capacity increases, the unstressed volume increases. So now, when there is venodilatation, the unstressed volume increases and reaches a volume of approximately 5 liters of the total blood volume. The remaining half liter is now the stressed volume. Thus, with venodilatation, the stressed volume decreases, and the decrease in the stressed volume would thus result in a decrease in the mean circulatory pressure. Now, let's elaborate more on the factors which determine the venous return. These factors include the blood volume, the venous capacity, sympathetic activity, the skeletal muscle activity, venous valves, the respiratory activity, and also gravity. So the first factor is the blood volume. We mentioned earlier in the lecture that at constant venous capacity, as the blood volume increases, the unstressed blood volume remains the same, while the stressed volume increases, and the increase in the stressed volume would increase the mean circulatory pressure, hence the venous return is increased. On the other hand, at constant venous capacity, as the blood volume decreases, like what we have in hemorrhage, the unstressed volume remains the same, while the stressed volume decreases. The decrease in the stressed volume lowers the mean circulatory pressure, hence the venous return is also lowered. The second factor which influences the venous return is the venous capacity, which is defined as the volume of the blood that the veins can accommodate. It depends on the distensibility of the walls of the veins and the influence of any externally applied pressure squeezing inward on the veins. At a constant blood volume, as the venous capacity increases, more blood spends a longer time in the veins instead of being returned to the heart. Thus, the effective circulating blood volume decreases and the venous return is decreased. At a constant blood volume, as the venous capacity increases, the unstressed blood volume increases and the stressed blood volume decreases. And the decrease in the stressed blood volume would result in a lowered mean circulatory pressure, and when the mean circulatory pressure is lowered, venous return also decreases. The opposite is true when the venous capacity decreases at a constant blood volume. A decrease in the venous capacity at a constant blood volume would result in an increase in the venous return. The second factor which determines the venous return is the sympathetic activity. The venous smooth muscle cells which we have in the walls of the veins are profusely supplied with sympathetic nerve fibers. Sympathetic stimulation results in venoconstriction, and venoconstriction, as we described earlier, results in modest increase in the mean circulatory pressure, hence the venous return increases. Sympathetic stimulation decreases the venous capacity because with sympathetic stimulation there is venoconstriction, and when the venous capacity is decreased, venous return increases, as we mentioned in the previous slide. What do you think the effect of venoconstriction on the resistance to flow? The veins normally have such a large diameter that with moderate venoconstriction as a result of sympathetic stimulation, the effect on the resistance to flow would be little. The third factor which determines the venous return is the activity of the skeletal muscle. Skeletal muscle contraction results in external venous compression. Thus, skeletal muscle contraction lowers the venous capacity, and when the venous capacity is lowered at a constant blood volume, the mean circulatory pressure increases and the venous return increases. This is known as the skeletal muscle pump. Skeletal muscle pump also counters the effects of gravity on the venous return. The fifth factor which affects the venous return is the competency of the venous valves. The valves which we have in the veins permit blood to move forward towards the heart, but prevent blood from moving back towards the tissues. These valves thus also play a role in counteracting the effects of gravity on the venous return in the upright position. Skeletal muscle pump is, however, ineffective when the venous valves are incompetent. Thus, when the venous valves are incompetent and there is chronically raised pressure in the veins, the chronically raised pressure in the veins leads to pathologically distension of the veins, and this is clinically known as varicose veins. Also, the increased capillary filtration leads to swelling, edema, with trophic skin changes and ulceration, and this is clinically known as venous ulcers. The other factor which determines the venous return is the respiratory activity, which is physiologically known as the respiratory pump or the thoracic pump. As the venous system returns blood to the heart from the lower regions of the body, the blood travels through the chest cavity. The pressure in the chest cavity, the intrathoracic pressure, is approximately 5 millimeters of mercury less than the atmospheric pressure. The venous system in the limbs and in the abdomen is subjected to the normal atmospheric pressure. Hence, an externally applied pressure gradient exists between the lower limbs and the chest veins, and this promotes venous return. This is known as the respiratory pump. Having described the effect of the respiratory activity on the venous return, what do you think the effect of the Valsalva maneuver on the venous return? The Valsalva maneuver involves forced expiration against a closed glottis or a closed mouth or closed nostrils. Hence, it markedly elevates the intrathoracic pressure. Hence, the venous return is lower. We use Valsalva maneuver when we lift heavy objects or when we have constipation. The seventh factor which affects venous return is gravity. This figure summarizes the effects of gravity on the venous pressures in the veins in the different parts of the body when someone is in the recumbent position and when the same subject is in the standing position. In the recumbent position, which is the supine position or the lying down position, the venous pressure in the veins at the level of the heart is positive 3 millimeters of mercury, and the venous pressure increases slightly in the veins above the level of the heart and also increases in the veins below the level of the heart, with the maximum venous pressure in the veins of the feet. In the standing up position, the venous pressure in the veins at the level of the heart is 0, and now gravity would have marked effects on the venous pressure. Thus, the venous pressures in the veins above the level of the heart would have increasingly negative venous pressures, while the veins below the level of the heart would have increasingly positive pressures, with the maximum pressure in the veins of the feet. As you all know, venous compliance is high and the veins have high distensibility. Thus, upon standing from the supine position, most of the blood volume shift occurs in the veins. As a result of that, venous volume and pressure become very high in the feet and in the lower limbs when someone is in the standing position. This shift in blood volume decreases the thoracic venous blood volume, and therefore the central venous pressure decreases. The decreases in the central venous pressure decreases the right ventricular filling pressure. Hence, the right ventricular preload is decreased, and this leads to a decline in the stroke volume by the Starling mechanism. Left ventricular stroke volume also falls as a result of the reduced pulmonary venous return, because the left ventricular preload is decreased, and as a result the cardiac output, the left ventricular cardiac output, and the mean arterial blood pressure fall. If the mean arterial blood pressure falls appreciably upon standing, this is termed physiologically as orthostatic or postural hypotension. This fall in the mean arterial blood pressure when someone assumes a standing position from the supine position can reduce cerebral blood flow to the point where a person might experience syncope and undergoes fainting. However, in normal subjects, when someone assumes a standing position from the supine position, the arterial baroreceptor reflex is activated and minimizes the effect of gravity on the mean arterial blood pressure, and this was explained in details in the previous lectures. Having finished with the detailed description of the factors which influence the venous return, let's describe an important curve in physiology, which is the venous return curve. This curve is also known as the vascular function curve. This curve shows the relationship between the right atrial pressure, the central venous pressure in millimeters of mercury on the x-axis, and venous return in liters per minute on the y-axis. Remember, we mentioned earlier in the lecture that the venous return is driven by the pressure gradient between the venous pressure nearest to the tissue, which is the mean circulatory pressure, and the venous pressure nearest to the heart, which is the right atrial pressure. Hence, when the right atrial pressure is equivalent to the mean circulatory pressure and having a value of 7 millimeters of mercury, no gradient exists between the pressure gradient nearest to the tissues and the venous pressure nearest to the heart, and accordingly the venous return would be 0. As the right atrial pressure, as the central venous pressure decreases, a pressure gradient is now established between the venous pressure nearest to the tissues and the venous pressure nearest to the heart, and the venous return increases. And at a value of approximately positive 1 millimeter of mercury, which is the normal right atrial pressure at rest, the venous return is approximately 5 liters per minute. From this curve, it is evident that there is an inverse relationship between venous return and right atrial pressure, because as the right atrial pressure decreases, venous return increases, and as the right atrial pressure increases and becoming closer to the mean circulatory pressure, the pressure gradient is decreased and hence the venous return decreases. This inverse relationship between the venous return and the right atrial pressure is explained as follows. As you all know, venous return is the return of the blood back to the heart. So like all blood flow, it is driven by a pressure gradient. The lower the pressure in the right atrium, the higher is the pressure gradient which drives the venous return, and hence the greater is the venous return. Thus, as the right atrial pressure increases and the right atrial pressure having values closer and closer to the mean circulatory pressure, the pressure gradient which drives the venous return decreases and the venous return also decreases. The flat portion, which is known as the knee portion of the venous return curve, it occurs at negative values of right atrial pressure. At such negative values, the veins would collapse, and this collapse of the veins impedes blood flow back to the heart. Thus, although the pressure gradient has increased as the right atrial pressure becomes negative, venous return levels off because the veins have collapsed. Now let's describe the effects of changes in blood volume and changes in the venous capacity on the venous return curve. Here we have again the venous return curve, the vascular function curve with the right atrial pressure on the x-axis and the venous return on the y-axis. An increase in the blood volume or a decrease in the venous capacity when there is venoconstriction would result in an increase in the mean circulatory pressure as we described earlier in the lecture, and hence the venous return curve, the vascular function curve, is shifted up. So this is the venous return curve with normal blood volume and normal venous capacity, and this is the venous return curve with an increased blood volume or with a decreased venous capacity when there is venoconstriction. If the blood volume increases, the amount of the blood in the unstressed volume will be unaffected, will remain the same, but the amount of the blood in the stressed volume will increase. And as we described earlier in the lecture, when the stressed volume increases, the mean systemic pressure, the mean circulatory pressure increases, and hence the vascular function curve and its intersection point with the x-axis shift to the right. The same effect is seen with venoconstriction. On the other hand, when the blood volume decreases or when the veins undergo venodilatation and the venous capacity increases, these effects would lower the mean circulatory pressure, and the venous return function curve is shifted down along with its intersection point with the x-axis. Thus, if the blood volume decreases, the stressed volume decreases, and the mean systemic, the mean circulatory pressure decreases, and the vascular function curve, the venous return curve, and its intersection point with the x-axis shift to the left. The same effect is seen when the veins undergo venodilatation and the venous capacity increases. Now, let's describe the effects of changes in the total peripheral resistance on the venous return curve, on the vascular function curve. The curve in white is the venous return curve with normal total peripheral resistance. The curve which is pink in color, this is the venous return curve with reduced total peripheral resistance. The curve which is red in color, this is the venous return curve with increased total peripheral resistance. Thus, it is evident that changes in the total peripheral resistance would not affect the mean systemic pressure, would not affect the mean circulatory pressure. However, when there is vasodilatation and the total peripheral resistance decreases as a result, for any given right atrial pressure, for any given central venous pressure, venous return is increased. In other words, decreased resistance of the arterioles decreases the total peripheral resistance, and it makes it easier for the blood to flow from the arterial to the venous side of the circulation and back to the heart. On the other hand, vasoconstriction elevates the total peripheral resistance, and when the total peripheral resistance is elevated, for any given right atrial pressure, venous return is decreased. In other words, increased resistance of the arterioles increases the total peripheral resistance, and it makes it more difficult for the blood to flow from the arterial to the venous side of the circulation and back to the heart. Now, let's combine the two curves which describe the functions of the cardiovascular system together. These two curves are the cardiac function curve, the Starling's curve of the heart, which we described in details in the previous lectures, and the venous return curve, the vascular function curve, which we have just described. So on the x-axis we have the right atrial pressure in millimeters of mercury, and on the y-axis we have the cardiac output and the venous return in liters per minute. When the cardiac output and the venous return are plotted simultaneously as function of the right atrial pressure, they intersect at a single value of the right atrial pressure. At this one value of the right atrial pressure, cardiac output equals the venous return. Both are 5 liters per minute, and by definition this value of the right atrial pressure is the steady state operating point of the system. That one value of the right atrial pressure satisfies both cardiac output and venous return relationship. We mentioned that cardiac output is directly proportional to the right atrial pressure. As right atrial pressure increases, cardiac output increases. However, venous return shows an inverse relationship with the right atrial pressure. As right atrial pressure increases, venous return decreases. At the steady state operating point of the system, the two values of the cardiac output and the venous return would be equal, and this operating steady state value of the right atrial pressure satisfies both cardiac output and venous return relationships. Here we have again the combined cardiac function curve and the venous return curve, and this is the equilibrium point where the cardiac output and the venous return are equal at a right atrial pressure of approximately 1 or 0 millimeters of mercury. Now let's describe the effects of changes in blood volume on the combined cardiac function and venous return curves. Increases in blood volume as a result of transfusion of a large fluid volume into the circulation increases the amount of blood in the stressed volume, as we described earlier in the lecture, and hence the mean systemic pressure, the mean circulatory pressure increases, and this results in shifting of the venous return curve to the right along with its intersection point with the x-axis, indicating an increased mean circulatory pressure. The cardiac function curve is not affected with changes in blood volume. Thus, with increases in blood volume in the new steady state, the cardiac and the vascular function curves intersect at a new point, and at this new equilibrium point, the cardiac output and the venous return are both increased, and the right atrial pressure is also increased. Here we have again the combined cardiac function and venous return curves when the blood volume increases. Decreases in blood volume would have the opposite effects on the vascular function curve. Now let's describe the effects of inotropic agents on the combined cardiac and vascular function curves. Positive inotropic agents produce an increase in contractility. This is the cardiac function curve with normal contractility. This is the cardiac function curve with increased contractility as a result of positive inotropic agents. The increased contractility increases the stroke volume and hence increases the cardiac output for any given level of the right atrial pressure. Thus, the cardiac function curve shifts upwards. The shift is counterclockwise, but the vascular function curve, the venous return curve, is unaffected. Thus, there will be, this is now the new equilibrium point. As a result of the positive inotropic effect of the positive inotropic agents, there will be substantial increases in both the cardiac output and the venous return, while the right atrial pressure is decreased. The opposite is true with negative inotropic agents. This is the new operating point with the negative inotropic effect of the negative inotropic agents, where we have substantial decreases in both the cardiac output and the venous return, while the right atrial pressure is increased. Let's describe now the effects of increased sympathetic nervous system tone on the combined cardiac function and venous return curves. Increased sympathetic nervous system tone rotates the cardiac function curve counterclockwise. It shifts the cardiac function curve upwards. This is, as we described in details in previous lectures, this is due to its boosting of the cardiac contractility and heart rate. Additionally, sympathetic nervous system stimulation reduces the venous capacity, and hence the mean circulatory pressure increases, because with the decreased venous capacity, this unstressed volume decreases and the stressed volume increases, and hence the mean circulatory pressure increases, and as a result the venous return curve, the vascular function curve, is shifted up, is shifted to the right, along with its intersection point at the x-axis, indicating an increase in the mean circulatory pressure. The combined effect of these changes is now we have new equilibrium point, where we have substantial increases in both the cardiac output and the venous return without a large change in the right atrial pressure. The right atrial pressure has remained almost unchanged with the increased sympathetic nervous system tone. Let's now describe the effects of changes in the total peripheral resistance on the combined cardiac and vascular function curves. Changes in the total peripheral resistance alter both curves. The cardiac function curve changes because of a change in the afterload, and the vascular function curve changes because of a change in the venous return. Thus, with increased total peripheral resistance, here we have the cardiac function curve shifted down or shifted clockwise, and here we have the vascular function curve also shifted down, and now this is the new equilibrium point when there is increases in the total peripheral resistance. Thus, with increased total peripheral resistance, there is a substantial decrease in the cardiac output and also in the venous return, with almost no change in the right atrial pressure. The opposite is true when the total peripheral resistance is decreased. Thus, when the total peripheral resistance is decreased, the cardiac function curve is shifted up. This shifting is counterclockwise, and the venous return curve is also shifted up without a change in the mean circulatory pressure. And now the equilibrium point has shifted up, indicating a substantial increase in both the cardiac output and the venous return, with almost no change in the right atrial pressure. Lastly, let's describe the combined cardiac and vascular function curves in cases of heart failure. This is the cardiac function curve when the heart is normal, and this is the venous return curve when the heart is normal, and A is the equilibrium point where the cardiac output and the venous return are equal and are approximately 5 liters per minute, and the right atrial pressure is approximately 1 or 1.5 millimeters of mercury. When the heart fails, the cardiac function curve shifts down and to the right. So this blue curve, this is the cardiac function curve of the failing heart with normal sympathetic stimulation. Now, the new equilibrium point is P, and at this new equilibrium point there is a substantial decrease of both the cardiac output and the venous return, while the right atrial pressure has increased. Now, when the heart has enough time, when the heart and the body have enough time to compensate, the sympathetic nervous system activity increases, and when the sympathetic nervous system activity increases, this shifts the cardiac function curve up. So this is the cardiac function curve of the failing heart with increased sympathetic activity, and this is the cardiac function curve of the failing heart with even more sympathetic activity. Sympathetic activity also increases the venous tone. It causes venoconstriction, reducing the venous capacity, and when the venous capacity is decreased, the mean circulatory pressure increases, as we described earlier, and the venous return curve shifts up and to the right. So now, with compensation with increased sympathetic activity, the equilibrium point shifts up from B to C, and at this new equilibrium point there will be increases in both the cardiac output and the venous return, while the right atrial pressure is not increased further. This is good. This is good to the heart. Other compensatory mechanisms operate when the heart fails, and these include fluid retention, and we have described this in details in the lecture on heart failure. And when there is fluid retention, the venous return curve shifts more to the right, and now we have a new equilibrium point. So the equilibrium point shifts from C to D, and at this new equilibrium point, the cardiac output and the venous return haven't shown increases. They would remain the same, but the right atrial pressure has increased. Hence, this compensatory mechanism, which is fluid retention, is not actually that beneficial to the failing heart, because it didn't lead to increases in the cardiac output or the venous return, but it results in an increase in the right atrial pressure. With more fluid retention, the vascular function curve shifts more to the right, and here we have the new operating equilibrium point when there is more excessive fluid retention, and hence the equilibrium point now shifts from D to E, and at this new equilibrium point, again there are no increases in the cardiac output or the venous return, but the right atrial pressure has increased further. Hence, with excessive fluid retention, the failing heart would not benefit. The heart would benefit more from the increased sympathetic activity. And that's the end of this lecture, and thank you very much for listening.